Welcome to this board review on mechanical ventilation, brought to you by Roadmap to Residency. Mechanical ventilation questions scare a lot of test takers, but on the exam they follow a small number of predictable patterns. Today we are not going to reteach the entire physiology of the lungs. Instead, we are going to show you how the question stems are built around 4 high-yield areas: when to intubate, how to pick the ventilator mode, how to read and adjust the settings, and how to know when a patient is ready to come off the ventilator. Keep your question bank and a trusted critical care review resource open alongside this video, because these patterns lock in only when you drill them. Let us get started. Here is our roadmap for today. First, we will learn to recognize when a patient actually needs to be intubated by spotting the failure to oxygenate, the failure to ventilate, or the failure to protect the airway. Second, we will sort out the ventilator modes you need to know, which are assist control, synchronized intermittent mandatory ventilation, and pressure support. Third, we will read the ventilator settings and the blood gas together and learn which knob to turn for which problem. Fourth, we will cover weaning and extubation and how the stem signals that a patient is ready to come off. Along the way, we will walk through several practice questions and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your critical care review resource. We are here to sharpen how you take the test. Our first strategy is to read every ventilation vignette by going to the last line first. That sentence tells you whether the question wants you to decide on intubation, pick a mode, or adjust a setting. Once you know the real question, go back to the stem with that goal in mind and you will stop drowning in numbers. Now here is the single most useful pattern for intubation questions. Almost every one of them maps to one of 3 failures. The first is failure to oxygenate, where the oxygen level stays low even on a face mask. The second is failure to ventilate, where the carbon dioxide level climbs and the blood becomes acidic. The third is failure to protect the airway, where the patient is obtunded, classically with a Glasgow coma scale at or below 8. When you read an intubation stem, your only job is to decide which of those 3 failures the writer is describing. Once you name the failure, the answer almost always falls out on its own. Strategy 2 is choosing the ventilator mode, and the trick is to map the mode to where the patient is in their course. There are 3 modes you must know cold. Assist control delivers a full, complete breath every single time, no matter whether the machine triggers the breath or the patient does. Because it does the most work for the patient, assist control is the standard starting mode right after intubation, and it is the safe answer when the stem describes a sick, freshly intubated patient. As the patient gets better, the questions move toward weaning modes. Synchronized intermittent mandatory ventilation delivers a set number of mandatory breaths and then lets the patient take their own breaths in between, so it is handy for a gradual, controlled wean. Pressure support has no mandatory rate at all. It only boosts the breaths the patient initiates, so it leans entirely on the patient's own drive and is used to test whether they are ready to come off. So when you see a mode question, simply ask where in the course this patient is. Just intubated and unstable points to assist control, improving and weaning points to synchronized intermittent mandatory ventilation or pressure support. Strategy 3 is reading the settings and knowing which knob to turn. Here is the framework that solves most adjustment questions. Split the blood gas into 2 separate problems. If the oxygen level is too low, you fix oxygenation, and the 2 oxygenation knobs are the fraction of inspired oxygen and the positive end expiratory pressure. If the carbon dioxide level is too high, you fix ventilation, and the 2 ventilation knobs are the respiratory rate and the tidal volume. So name the abnormal value first, then turn the matching knob. Next, protect the lung. In acute respiratory distress syndrome, the single highest yield answer is low tidal volume ventilation, around 6 milliliters per kilogram of ideal body weight, aiming to keep the plateau pressure under 30. If the plateau pressure is climbing in a stiff lung, the answer is to lower the tidal volume, not to push in more air. Finally, read the alarm before you act. A sudden high peak pressure alarm with a distressed patient is a classic stem. Run the quick differential the writers love: a kinked or blocked tube, a mucus plug, the patient biting the tube, bronchospasm, or a pneumothorax. The correct first move is usually to disconnect the patient, bag them by hand, and pass a suction catheter, rather than blindly increasing the settings. Let us work through our first practice question, and this one is built to test the 3 failures pattern for intubation. A 70-year-old man is brought to the emergency department after a large stroke. He is very hard to arouse. He does not respond to your voice, and his Glasgow coma scale is 6. He has shallow breathing, Secretions are pooling in the back of his throat, and his gag reflex is absent. Here is the key trap. His oxygen level is 94% on a face mask, which looks reassuring. The question asks for the most appropriate next step. Before you choose, decide which of the 3 failures this is. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. The oxygen level of 94% is bait, and it is there to make you relax. The findings that actually matter are a Glasgow coma scale of 6, an absent gag reflex, and secretions pooling in the throat. This is the third failure to protect the airway. Next, apply the rule. A patient who cannot protect his own airway needs a definitive airway, and that means intubation. The classic teaching is that a depressed mental status, with a Glasgow coma scale at or below 8, together with a lost gag reflex, means you must secure the airway. So the answer is to intubate to protect the airway. Now eliminate the wrong answers. A nasal cannula and observation ignores the airway and invites aspiration. Non-invasive positive pressure ventilation is a trap because it requires an awake, cooperative patient who can protect the airway, and this man cannot. Increasing the oxygen flow chases a number that is already fine and delays the real fix. The answer is to intubate to protect the airway. Notice that the oxygen number was never the point. The airway was. Here is our second practice question, and this one tests how you adjust the ventilator. A 60-year-old woman with severe pneumonia is intubated for acute respiratory distress syndrome. She is on assist control with a high fraction of inspired oxygen. Now read the blood gas carefully, because it is doing the work for you. Her carbon dioxide level is normal and her blood acidity is normal, so ventilation is fine. The only problem is that her oxygen level stays low. On top of that, her tidal volume is set high at 10 milliliters per kilogram, and her plateau pressure is climbing above 30. The question asks for the next best adjustment. Before you answer, sort the problem. Is this an oxygen problem or a carbon dioxide problem? And is the lung being injured by high pressure? Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, sort the blood gas. The carbon dioxide level is normal and the blood acidity is normal, which means ventilation is fine, so do not touch the respiratory rate. The only abnormal value is the oxygen level, and that makes this an oxygenation problem. Remember, the 2 oxygenation knobs are the fraction of inspired oxygen and the positive end expiratory pressure. Raising the positive end expiratory pressure opens up collapsed lung and improves oxygen, which is exactly what she needs. Now the second half of the question, why lung protection wins. Her tidal volume is set too high at 10 milliliters per kilogram, and her plateau pressure is climbing above 30, which is actively injuring the lung. In acute respiratory distress syndrome, the answer is to lower the tidal volume towards 6 milliliters per kilogram. So the single best move combines both ideas. Lower the tidal volume and raise the positive end expiratory pressure. Let us eliminate the rest. Increasing the respiratory rate treats a carbon dioxide problem that does not exist. Raising the tidal volume to push in more oxygen is the dangerous overkill answer because it worsens lung injury. Switching to pressure support and weaning is far too early in a patient who cannot oxygenate. The answer is to lower the tidal volume and raise the positive end expiratory pressure. Let us lock in the cheat sheet that solves almost every ventilator adjustment question. The whole trick is to separate oxygen problems from carbon dioxide problems. First, fix oxygen with 2 knobs. When the oxygen level is low, you turn the oxygenation knobs, which are the fraction of inspired oxygen, and the positive end expiratory pressure. Raising the positive end expiratory pressure opens collapsed lung and improves oxygen. And you want to avoid sitting on a very high fraction of inspired oxygen for a long time, because too much oxygen is itself toxic to the lung. Second, fix carbon dioxide with 2 knobs. When the carbon dioxide level is high and the blood is acidic, you turn the ventilation knobs, which are the respiratory rate and the tidal volume, because increasing either one blows off more carbon dioxide. There is one important exception to memorize. In acute respiratory distress syndrome, lung protection comes first, so you raise the respiratory rate rather than the tidal volume, and you accept a mildly high carbon dioxide level. So on test day, name the abnormal value first, decide if it is an oxygen problem or a carbon dioxide problem, and then reach for the matching pair of knobs. That single habit will carry you through the majority of settings questions you see. Here is our third practice question, and it is all about recognizing readiness to come off the ventilator. A 50-year-old man was intubated 3 days ago for pneumonia. Now read the STEM like a checklist, because the writers are handing you every readiness criterion on purpose. He is awake and following commands, so his mental status is fine. The cause of his respiratory failure has resolved. He is on minimal settings, with a low fraction of inspired oxygen and a low positive end expiratory pressure. He has a strong cough, which tells you he can clear his own secretions. And he just passed a spontaneous breathing trial, breathing comfortably for 30 minutes with stable vital signs. The question asks for the next best step. When a patient checks every one of those boxes, the test wants a specific action. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, run the readiness checklist, because the STEM deliberately hands you every box already checked. The cause of his respiratory failure has resolved. He is awake and following commands, so his mental status is fine. He is on minimal settings, with a low fraction of inspired oxygen and a low positive end expiratory pressure. He has a strong cough, which means he can clear his own secretions and protect his airway. And he just passed a spontaneous breathing trial, breathing comfortably for 30 minutes with stable vital signs. When a patient checks every one of those boxes, the next step is to take him off the ventilator. The answer is to extubate the patient. Now, the key distinction between the wrong choices. Switching him back to full assist control throws away real progress and keeps him on the ventilator longer, which raises his risk of pneumonia. Raising the positive end expiratory pressure is treating an oxygen problem he no longer has. A tracheostomy is reserved for patients who cannot be liberated after prolonged ventilation, not for a man who just sailed through his breathing trial on day 3. Every wrong answer either delays or overtreats. The correct answer is to extubate the patient. Here is the pearl that ties all of these questions together. Ventilation stems almost always hide one of two traps, and if you learn to spot them, you will get these questions right, even when the physiology feels intimidating. The first trap is the reassuring number. The writers place one comfortable value in front of you to make you relax, while the real emergency is sitting somewhere else. An acceptable oxygen level next to a Glasgow coma scale of 6 is still an airway emergency. A normal carbon dioxide level next to a rising plateau pressure is still a lung being injured. Never let one good number override a dangerous one. The second trap is the overkill answer, the dramatic choice that does too much. Pushing in more tidal volume to fix oxygen, jumping straight to a tracheostomy, or reaching for intubation when non-invasive support would do, are all built to feel decisive and bold. On this exam, the measured move almost always wins. Protect the lung, treat the value that is actually abnormal, and pick the least invasive option that truly solves the problem. Spot the reassuring number, refuse the overkill answer, and these questions become predictable. That wraps up our review of mechanical ventilation. Let us lock in the core ideas. For intubation, sort every STEM into one of 3 failures: failure to oxygenate, failure to ventilate, or failure to protect the airway. For modes, match the mode to where the patient is in their course, with assist control right after intubation and synchronized intermittent mandatory ventilation or pressure support as they wean. For settings, split the blood gas into an oxygen problem or a carbon dioxide problem, then turn the matching pair of knobs, and always protect the lung in acute respiratory distress syndrome with low tidal volume. For weaning, look for the patient who is awake, on minimal settings, with a strong cough, who passes a spontaneous breathing trial and then extubate. And remember the 2 traps. Do not be fooled by the reassuring number, and do not reach for the overkill answer. To master the underlying material, work through the respiratory failure and mechanical ventilation chapters in a trusted critical care review resource, and drill the pulmonary and critical care questions in your question bank under timed conditions. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next one.